Thank you for joining the Safe and Appropriate Cesarean Delivery in Low Resource Settings Community of Practice meeting today. My name is Vandana Tripathi. I am the director of the Momentum Safe Surgery in Family Planning and Obstetrics Project, which hosts this community of practice. Today, you'll be hearing about innovations in quality care and patient follow-up in DRC, India, and Rwanda. Next slide, please. Before we get started, we want to remind you that there is interpretation today. So if you go into your meeting controls and select the interpretation icon, you'll be able to click on the language that you'd like to hear in. Next slide, please. So we have a wonderful panel for you today, and you have their bios in the agenda materials you received when you registered. So I won't go into all of their bios, but please do take a look. We'll be getting 3 presentations today, and they'll all go in a row, and then we will have time for questions and discussion after that. I do want to mention that you can submit your questions through the Q&A function that you'll also see in your webinar controls. We'll try to answer a number of those questions in writing as the webinar proceeds, and then again, we will have time for a discussion at the end. Before I turn to our panel, just want to share an overview of this community of practice. Next slide, please. So we are hosted in the Momentum Safe Surgery Project, which is one of 6 USAID supported Momentum Awards, all working to accelerate reductions in maternal, newborn, and child mortality and morbidity. Momentum Safe Surgery works in the countries that you see here, and we work to strengthen care in surgical obstetrics, the prevention and treatment of iatrogenic and obstetric fistula, and surgical methods of family planning. Next slide. We are a consortium led by EngenderHealth, where I am based, but working closely with the implementing and resource partners that you see here, several of whom will be sharing their experiences today. Next slide, please. We are working to strengthen the safe surgery ecosystem in 4 phases: how people seek surgical care, their ability to reach it, the quality care they receive when they do get there, and linkages after discharge from surgical care. The innovations you're going to hear about today focus primarily on those 3rd and 4th phases: receiving quality care and staying connected after discharge. Next slide, please. The community of practice itself is intended to be a global resource for surgical obstetric care. We want to catalyze strategic change and empower actors globally, regionally, and at the country level with solutions to the challenges we all know about, the things that hinder people's ability to get safe, quality, and appropriate cesarean delivery in low resource settings. We want the community of practice to be a place where people can share their experiences, hopefully identify common ground and opportunities for collaboration, and accelerate action in this space. The community of practice was launched last year at the FIGO World Congress with an in-person event, significantly smaller than this one, but it was our first opportunity to bring people together. At that event, representatives of a number of organizations shared tools and resources to improve cesarean care. These included WHO's Global Robson platform, new training manuals for surgical obstetrics, and new diploma courses to shore up the skills of new clinicians. Next slide, please. We'd love for folks joining us today to stay involved. So at the website that you see here and at the QR code, you can find further information about the COP, an expression of interest form if you'd like to stay connected, and we will use this site to share information on future events, recordings from webinars, and ultimately a resource clearinghouse. And we'll come back to that resource clearinghouse at the end of today's event. So again, you have the bios of everybody in your materials. So I won't stop to introduce people, but I'm so excited to have this panel for you joining us today. Next slide, please. Our first presentation will be on a new Cesarean Safety Checklist, and you'll be hearing from Rose Molina of Ariadne Labs and Harvard Medical School, Manoj Paul of Momentum Safe Surgery and EngenderHealth, and Meg Long, also of Ariadne Labs. So thank you again for joining us, and over to you. Thanks.
Wonderful. Thank you so much. And welcome to everyone who has joined us today. We're excited to share a little bit about this work. We can move forward to the next slide, please. Thanks. So our partnership between Ariadne Labs and MSSFPO started in 2023 and grew out of a longstanding interest in innovating on lessons learned from both the WHO Safe Surgery Checklist and the WHO Safe Childbirth Checklist. We were especially interested in applying those lessons learned to improve the safety, quality, and dignity of cesarean birth care specifically, because we know that there are unique features of cesarean birth that set it apart from other surgeries and even from the experience of vaginal birth. We identified an opportunity to develop a cesarean safety checklist with end users in public facilities in India. We brought our expertise in human-centered design, clinical obstetrics, and systems improvement to the prototype development process, which took place in October 2023 through June of 2024. Next slide, please. So to set the context for this project, it's important to note that cesarean birth rates are rising around the world for a variety of reasons. It's also important to note that cesarean births are associated with higher risk of morbidity and mortality for both the mother and the newborn compared with vaginal birth. For example, as listed here, some of the short and long-term adverse outcomes that are more frequent among cesarean births include infection, hemorrhage, and hysterectomy for the mother, and respiratory distress and hypoglycemia for the newborn. Next slide. Research has shown that there are multiple key drivers of adverse events in cesarean birth. The first driver listed here is gaps in evidence-based practices, also known as the no-do gap. Consistent implementation of evidence-based practices for every patient every time remains a challenge in many settings. The second driver listed here is poor team communication during handoffs and other key moments of care. For example, there is critical information that needs to be communicated across different care team members, especially as patients move from the labor ward to the operating theater to the recovery or postpartum ward. And this is really important to minimize safety events and provide the highest quality of care. The next driver listed here is unclear systems processes, especially during complications that might arise during cesarean birth. So for example, those of you in the audience who have been part of a surgical team during emergency cesareans know that those are very high stakes operations and are prone to poor communication in a chaotic environment due to the acuity and urgency of the situation. Lastly, as listed here, we know that lessons learned from the WHO Safe Surgery Checklist include that poor teamwork and safety culture are associated with increases in perioperative morbidity and mortality. Teamwork and safety culture is especially important in the operating theater where traditional medical hierarchy might stifle interprofessional collaboration. So specifically, if nurses don't feel comfortable speaking up about safety events, we know that that has been shown to be associated with worse outcomes in the perioperative setting. Next slide. Earlier in 2023, our team led a landscape analysis through the Momentum Knowledge Accelerator to synthesize what checklists might already exist for cesarean birth and identify a unique value add for our work. In that landscape analysis, we found 15 checklists and 6 global or India-specific guidelines related to cesarean birth. However, of those 15, only 3 were explicitly focused on communication, and the majority were either accountability tools or clinical decision aids. Another limitation that we found in our landscape analysis is that of the few checklists that we were able to identify, very few included all care team members, especially at important moments before and after the birth. Next slide. So based on that landscape analysis, we identified a clear opportunity for innovation. We set out to co-create a team communication checklist designed specifically for cesarean births. Specifically, we identified a need for the checklist to, number 1, address communication failures at key moments in the perioperative care pathway between the labor ward, the operating theater, and the postpartum recovery ward. The second key feature is that the checklist builds a culture of safety and quality, especially among interprofessional team members. So acknowledging that it's not just obstetricians, but anesthetists and nurses and pediatricians who all form critical parts of the care team, in addition to the mother or patient herself. The third feature that we wanted to incorporate into the checklist was really to ensure that there were key clinical and health system considerations specific to cesarean birth included. So for example, preparing for common complications such as hemorrhage and making sure that, for example, uterotonics are available and assessing blood bank capacity for patients with clinical risk factors for hemorrhage. The fourth feature we wanted to include in our checklist prototype was innovation around integrating respectful maternal newborn care practices in the context of cesarean birth. As many of us know, there's been a large, important movement around the experience of childbirth care, and there has been relatively little written explicitly about how to deliver respectful maternal newborn care in the context of the operating room. So with that brief introduction, I'll pass it to my colleague Meg Long to share a bit more about our human-centered design process for developing the Cesarean Safety Checklist prototype.
Thanks so much, Dr. Molina. And hi, everyone. I'm Meg Long, and I'm the Assistant Director of our Innovation Platform at Ariadne Labs. And I was so pleased to partner with this team for this work and really thrilled to be with you all here today. Our mission at Ariadne is to design simple solutions that save lives and reduce suffering for patients around the world. And to do so, we use a human-centered design innovation pathway. And I'm going to walk you through how we applied this pathway to the design of the Safe Cesarean checklist. Next slide. But I want to start off with what is human-centered design? And by definition, HCD is a problem-solving approach that prioritizes the needs of real people. So by focusing on the experiences and perspectives of healthcare providers and patients, HCD can really help us create healthcare solutions that are effective, efficient, but also user-friendly. For the checklist, HCD was critical because we know that cesarean birth involves numerous healthcare professionals, each with different roles and challenges. And so by understanding each of their unique needs, we knew that we could design a tool that supports their work and also improves patient outcomes. Next slide. So this image is an example of human-centered design in action. This is a fun image of a CT scan machine in a New York City Children's Hospital. And we all know that hospitals and medical facilities are really scary places for kids. And this hospital recognized how getting a scan can be really traumatizing and anxiety producing for patients. And so this team got creative on how to make it a more positive experience. And you can see on this image, the medical team turned the scanner into a fun ship. And they found this simple design really helped enhance patient experience, but also helped them achieve critical goals and medical procedures. Next slide. So for the design of the Cesarean Safety Checklist, we took a three-pronged approach. And in the following slides, I'm going to go through each of the three phases of our work. Next slide. We began by interviewing 24 experts in obstetrics, anesthesia, pediatrics, nursing, and public health across 4 Indian states. And a few key themes emerged from these interviews. The first was around communication breakdowns. So we heard the care teams and patients often struggled to communicate with each other effectively, and that led to misunderstandings and errors. We also heard about documentation challenges, so overburdened staff really frequently missing critical documentation opportunities and therefore hindering continuity of care. And then we also heard about role ambiguity, a lack of clarity regarding roles and responsibilities amongst the care team members involved in cesarean birth. Next slide. And so we took all these learnings from the interviews and into the next phase of our work, which was a human-centered design workshop where we convened the people we interviewed and others in a 2-day workshop in New Delhi, India. And participants actively engaged in really hands-on HCD exercises in this workshop. The first exercise participants were involved in was journey mapping. So this is an exercise where we visualize the key steps in a cesarean birth to identify potential pain points along those steps. We then engaged in a prioritization exercise, so working with participants to determine the most critical evidence-based practices that they felt they wanted to include in the checklist. And then we got to prototyping. We asked all of the participants to sketch and design their own versions of a cesarean safety checklist. And we feel that this really hands-on approach empowered participants to contribute their expertise and visualize a final product that aligns with their needs and priorities. Next slide. After the workshop, our team reviewed the range of prototypes that were generated by participants at the workshop. You can see 2 examples of those prototypes on the left-hand side of the screen. And we distilled the core elements into a single unified design, and you can see that on the right-hand side of the screen. And our final prototype then went through 5 rounds of feedback from, again, those users we interviewed and who attended the workshop. And the result we're really proud of. It's a cesarean safety checklist that integrates principles of effective team communication, respectful patient care, and safety across all phases of the cesarean birth process. We believe that the human-centered design approach has really yielded a tool that healthcare providers can find both useful but also user-friendly. So I'll now hand the presentation over to Dr. Manoj Paul, who's going to discuss how the checklist can be integrated into current care practices and some of our plans for the future. Thanks so much.
Thanks, Meg. And we can go to the next slide. So while Meg was talking, she also mentioned that providers who came to the HCD workshop, they wanted this checklist to be integratable within the existing QI system and not create a new process which they have to go through. Also, they wanted that this checklist should reduce the documentation redundancy. So when we were thinking of how it would be implemented, the best bet that came up to us was to place this checklist within the pause point 2 and pause point 3 of WHO Safe Childbirth Checklist, which is already in use in the QI flow processes in India. Next slide, please. So you can see that this fits in between the pause point 2 and pause point 3, and it fills the gap that was there in the WHO Safe Childbirth Checklist when it comes to cesarean sections. Next slide, please. Also, we adapted the safe surgical checklist developed by WHO specifically for C-section, and we adapted the mom and baby specific guidances that should be there. And therefore, we could remove the usage of WHO safe surgical checklist with the addition of just 1 page of the safe cesarean checklist that we had developed. Next slide, please. As we can see, there is a QI process which is in place in India, and this checklist that we had developed fits in between the processes that are already existing and does not add to the burden of providers who are already providing services. Next slide, please. We also took a leaf from the checklist that were already there. There was a checklist which was developed by Foxy. It's called the GPCR, which talks about the clinical aspects of cesarean section. And this checklist, which we had developed, could add on to the Foxy checklist in terms of its usage. Next slide, please. So in end, we had, 3 deliverables that we have developed. One is the safe cesarean checklist prototype that we had developed. In addition to that, we developed a technical brief, and because we wanted to detail out the evidence and rationale for development of this checklist, so that any administrator who want to take up this checklist have a clear evidence of doing so. Additionally, we also developed a guidance for the clinical teams on how this checklist exactly has to be used during their daily routine. Next slide, please. So our priorities now are in development of the community, where we would be launching the community of practice this month. And we already have developed a protocol where for usability, feasibility, and acceptability testing of the checklist. And we are actively searching for partners and funders so that this checklist can be tested at various facilities, various level of facilities, and then can be scaled up further. Thank you so much. And any questions you can put down in chat. Thank you.
Thank you so much, Rose, Meg, and Manoj, for sharing that work. It's been very exciting to be part of this collaboration between Momentum Safe Surgery and Ariadne. And I know we will have questions for you when we come to the discussion. Next, I'd like to hand off, if we go to the next slide, please, to Bethany Het, next slide as well, thank you. Bethany Het Gauthier of Harvard Med School, who's going to share innovations from her team's work in Rwanda. Bethany, over to you. Thank you.
Thank you so much, and thank you for the invitation to be here. I am trying my best to represent about 10 years worth of work that includes dozens and dozens of collaborators in just 15 minutes or less. So I will try to jump to the most exciting and important parts of the conversation for the purpose of this presentation. I can see in the translation of the slides to the master slide deck, I tried to highlight the colleagues who've been the most involved in this particular piece of work that I'll be sharing today, and just want to recognize that, again, I'm just here as part of a much broader team. Next slide, please. I'm going to use this time to talk about two innovations that are really complementary to each other and ones that have fed off of each other, and use it as an opportunity to challenge how we think about innovations in the maternal health space. Next slide. Just a little bit of background about surgery in Rwanda. So all specialists, including surgical specialists and obstetricians, have been located in central locations up until 2016, when the Human Resources for Health program began aggressively training colleagues to be able to provide higher level clinical care. And you can see the density of surgeons, anesthesiologists, and obstetricians has increased over that time from 0.7 to 2.5 per 100,000. But there's been less focus on the staff, systems, and spaces that are needed to provide safe surgery and safe cesarean care in these contexts. And still largely these specialists are still located in larger cities. About 80% of operations are performed in district hospitals, and nearly all of these are cesarean deliveries that are provided by general practitioners. Next slide, please. So what are our team working towards in the research that I'll be sharing today? So our goal is access to high quality cesarean care in rural Rwanda. And over the last 10 years, there's been a heavy focus on the post-operative period. Next slide, please. So why have we been focusing on the post-operative period? Over a series of research studies, we've identified this as a critically important and often neglected time in recovery after a cesarean delivery. So for example, in an early study, we found that 11% of women go on to develop a surgical site infection after discharge. Over a series of studies, including the one highlighted here, we've demonstrated that the long distances from the home back to the health centers are linked to both poor maternal and poor neonatal outcomes. We've shown that in qualitative work, women have reported that cesarean follow-up, so the requirement to go back to health centers for physical examinations, is both physically burdensome and financially challenging. And then in financial assessment work, we've demonstrated that for 23% of families, the cesarean itself is financially catastrophic, but this increases to 77% when we are accounting for post-cesarean follow-up. Next slide, please. So our first innovation is really trying to address these challenges and gaps that we've observed in post-cesarean care. Additional information that we think is important to motivate this innovation is the fact that in our qualitative work, women reported that they were receiving conflicting information during the postpartum period about what cesarean recovery should be like. For example, women reported that what they might hear from a GP versus a nurse would be different at the time of discharge, or what a nurse told them to do for safe recovery would be different than what a neighbor might tell them to do. And so we're trying to address this conflicting information that they are receiving. As we were doing this, we did a systematic review and found that there's no standardized discharge instructions for women delivering via cesarean that focuses on the needs and resources specific to sub-Saharan Africa. Next slide. To address this gap, as a first step, we hosted a technical advisory group. Many of the colleagues who are engaged in this group are here to answer the questions about what women should be told during the postpartum period for safe recovery after cesarean delivery. So the questions that this group addressed were, what should they be told? When should they be told? When do they need to have contact with the health system after a cesarean delivery? And who should be communicating this information to women? You'll see from the technical advisory group, it was heavily weighted to focus on Rwanda, but we engaged experts from across East Africa and from across the globe to try and think about generalizability of these recommendations to other sub-Saharan African countries if appropriate. Next slide. The second phase of this project was thinking about how we could take these technical recommendations and then use them, effectively communicate these recommendations to women in Rwanda. We engaged a graphic designer who helped us develop content that was specific and imagery specific to Rwanda. So you can see here the adaptation of a photograph to the icons that were used throughout the communication tools. Next slide. And then we took these instructions and put them into, again, images that were easy to understand, but also some text to support the understanding of these. So the same information here that was in the flyer that was sent home with women, we also developed flip charts to support in-hospital counseling. Next slide. We implemented these tools with 30 women. 30 women received communication about post-discharge recovery and then were sent home with a flyer with the information. 30 women received this information using a flip book and counseling sessions at the hospital. And then we followed 30 women who did not receive the tool. And one of the most interesting findings across these different communication strategies was the level of confidence and our ability to increase confidence with the support of these tools. So for example, you can see here, I felt knowledgeable about caring for my body after cesarean section. Only 43% of women felt knowledgeable compared to 90% of women who received communication via the flyer and 100% of women who received communication with the support of the flipbook. You'll see similar results with women feeling more confident that they can identify issues if they arise after the cesarean delivery, and that they feel confident to know what to do if they have these complications after cesarean delivery, with higher levels of confidence among women who receive communication with the flyer and the flipbook. For the sake of time, I'm not sharing with you the qualitative results, but effectively we saw the same results in our qualitative study, and women recommended at the end of the study that we actually combine both the flyer and flipbook as strategies to facilitate communication. Next slide, please. Our second innovation, which builds off of this, we're exploring the use of mobile health tools to support home-based follow-up. So the gaps here that we're trying to fill are the fact that community health workers visit women and babies during the postnatal period in Rwanda. So they provide postnatal care to all babies, but they only provide postpartum care to women who deliver vaginally. Because of the increased complexity of medical recovery, women who deliver via cesarean are required to travel back to the health center for their postpartum and postoperative care, even though community health workers are already traveling to their home to provide postnatal care. The opportunity that we think this presents is addressing the question of, can we develop a mobile health tools to support women during the post-cesarean recovery And specifically, can we take advantage of the fact that community health workers are already visiting women to provide the postnatal care? Can we take advantage of that interaction and provide post-cesarean care as well? Next slide. This is part of the work that we've been developing over many, many years, and we've had several attempts. So in our first attempt, a community health worker would visit a woman in her home and administer a clinical screening protocol on the mobile device with the goal of identifying a surgical site infection. In the second attempt, we had community health workers capture a photo of the wound and send that image to a general practitioner for real-time review. Across these two studies, we found that it is both feasible, so we are able to support community health workers with mobile devices, that women are willing to allow community health workers into their homes, that we can transmit photographs via WhatsApp to GPs. So all aspects of these studies were feasible, and they were generally highly acceptable and then oftentimes preferred over hospital-based follow-up. However, what we found in these two studies is that even though it is feasible and acceptable, our approaches to surgical site infection diagnosis were failing. Specifically, we have low sensitivity in these two studies, so our ability to identify surgical site infections is not adequate. And for the GP reviews, if you take the same image and send it to two different general practitioners, we don't get consistency in the diagnosis across those general practitioners. Next slide. So we've been trying to improve within a third attempt that we're in the middle of now. And there's two things that we're addressing with this third attempt. The first is the fact that we need a better surgical site infection diagnostic tool. So we need a way to more accurately diagnose surgical site infections and to have better consistency across diagnoses. And then the second was that direct request from the Ministry of Health with the feedback that when we send community health workers to support post-cesarean follow-up, they need to be able to assess more than just surgical site infections. And so how do we make sure that the community health worker engagement of the woman is more comprehensive at that visit? Next slide, please. So for the surgical site infection diagnosis, we've been developing machine learning algorithms that will be able to predict surgical site infection based on the womb image itself. There are many components to this work, but some of the most important features. First, we've developed an app that can capture wound images in a standardized way. So it makes sure for training algorithms that all the images are standardized, but also when we apply this in the field, that community health workers can capture images that are oriented in the way that they need to be oriented, that are not blurry, that have good color resolution. We also have an optical target in the image capture that will allow us to standardize the images to different types of lighting that might make skin tones or wound images look more white or blue or green, depending on the tone of the light. So once we have these images, we've been training algorithms. The first algorithm is based just on the cameras that are already built into your phone. So all of us, many of us, I bet, on the call have smartphones. And so built into the phone are cameras. And just using the images from those cameras, we were able to train an algorithm that has 81% sensitivity and 65% specificity. We actually have newer results that have a higher specificity by applying these color calibrations to the wound images. In a second set of machine learning algorithms, we've actually been adding on devices to the phones. It's about $200 per device that captures thermal images. And with these thermal images, we're able to maintain similar sensitivity and have a much higher level of specificity using the thermal diagnostics. Next slide, please. For the more comprehensive assessments, we were able to lean into that first innovation that I showed you, where we were taking the different communication icons and instructions that were developed as part of the technical working group and with the graphic designer, and we're now putting these onto the phone and using them as a guided tool to walk community health workers through both clinical assessments and referrals, but also through counseling instructions. Next slide. We've just passed a series of usability testing with community health workers and have demonstrated that it's both usable and highly acceptable to community health workers. Next slide. We have also just recently completed a cohort validation study, and in this cohort validation study found that we had high accuracy both with our surgical site infection, but also to detect other post-cesarean conditions like postpartum depression and mastitis. And we're about to begin a cluster randomized trial to evaluate whether or not follow-up using this tool with community health workers will impact the time to diagnosis of post-cesarean complications. Another grant that we just received is evaluating whether or not these AI tools are generalizable across other settings. So, for example, if we take the algorithms developed in Rwanda, can they accurately diagnose surgical site infections in Ghana and Mexico? Next slide. So in conclusion, there are clear paths forward to improve care and outcomes of women delivering via cesarean in rural Rwanda. I want to emphasize that innovation comes in many forms. So oftentimes now people are drawn to AI or mobile tools, which do have an important role to play in high quality maternal health care in the context where we work. But we shouldn't ignore the more practical, pragmatic solutions in exchange for these bright and shiny objects. So the tool that the Ministry of Health is implementing or interested to implement now are the communication tools that we developed, the flyers and the flip books. So those are important, just as important as the mobile apps. So innovation doesn't matter if there's no focus on impact. And so as we've been developing these tools, we've been working to make sure that they integrate into patient care pathways. And I think that's important for any of us who are looking at new strategies to support maternal health care or post-cesarean care in these settings. Next slide. Many people to acknowledge here, and I put my email at the bottom in case anyone wants to follow up with me directly. I look forward to your questions and further discussion at the end of the next presentation. Thank you.
Thank you so much, Bethany, for sharing both the process and the results of that experience, and for reminding us and showcasing the large team that has been involved in this. I'm beginning to see questions for you coming in, and I know there'll be lots of interesting discussion on that as well. Now for our last presentation, before we go to reflections and discussion, you're going to hear about postnatal outcome surveillance by telephone in DRC. And you'll be hearing from Ona McCarthy from the London School of Hygiene and Tropical Medicine, Maxine Pepper, also from the London School, and Jean-Lambert Chala from Momentum Safe Surgery and EngenderHealth. Over to you. Thank you.
Yeah, thank you. Thank you so much, Vandana. So I'm Jean-Lambert, and I'm starting this presentation. I will be completed by my colleagues, Ona and Pepper. As you said, we are presenting the initial results from the post-cesarean outcome surveillance by telephone, a study led in the Democratic Republic of Congo. Next slide, please. Yeah, this is the core team for this study. As I present, some of them are based here in Kinshasa with me, and the others remote in London School and in the US. Next. So a few words about the background. Next, please. The literature review is showing the increase in cesarean deliveries, and most in low and middle income countries. What is important to know is that this increase in obstetric interventions, particularly cesarean delivery, also increases the risk of bacterial infections among these deliveries, and also other adverse outcomes. Next, please. So in DRC, maternal and neonatal mortality rates remain very high, as you are seeing. And after leaving the facility, women have little to no chance to contact with health services. This leads to the potential benefits of following up those women via telephone in the first month post-cesarean. So a study in Tanzania found telephone interviews successfully identified cases of postnatal infection. Next, please.
Thank you, Jean-Lambert. I'm Ona McCarthy from the London School of Hygiene and Tropical Medicine. So I'm going to talk you through some of the methods of the study. So our overall aim was to implement the PARL questionnaire among postnatal women with cesarean delivery to assess how useful it is as a surveillance tool. Our research objectives were to develop and pilot the questionnaire in the DRC, to assess how well it can be used within the current hospital systems, and to estimate the incidence rate of maternal and newborn infection within 28 days after birth. Our final objective was to describe mental health of women in the first 28 days post-cesarean delivery, along with other health concerns. Next slide, please. The PARL questionnaire is delivered by telephone by trained hospital nurses allocated to the PARL study. PARL staff called women at 7, 14, and 28 days after their delivery, and women could choose their PARL questionnaire to be in French, Lingala, or Swahili. PARL staff entered the answers to the questionnaire directly onto tablets using software called Open Data Kit. The majority of questions were around infection symptoms, and women and babies' names were pulled from the previous questionnaire for a more personalized experience. Next slide, please. The study was conducted in 3 hospitals in the DRC. 2 of the hospitals were in the east of the country, which were Heal Africa in Goma, North Kivu, and Panzi in Bukavu, South Kivu. St. Joseph was the 3rd hospital, which was in Kinshasa in the west. Our target sample size was 660 women, and women who had a cesarean delivery were aged 15 or over and who had access to a phone were eligible. They were recruited during the normal discharge process where informed consent was sought. Next slide, please. So at each time point, the PARL nurses attempted to reach each woman up to 4 times. For the initial analysis in this presentation, we're reporting infection and calls completed at each time point and the results from the interviews of staff. Next slide, please. So this is a description of the data collected at each time point. At enrollment, we collected demographic, pregnancy, and birth-related data from the hospital records. On day 7 and 14, we collected data on infection symptoms, care seeking, neonatal mortality, and feeding. On day 28, we collected these same data, plus data on fistula symptoms and mental health. And mental health was measured using the Edinburgh Postnatal Depression Scale 5. Next slide, please. Now we'll present some of the initial results. Next slide. We exceeded our target sample size of 660. So after data validation, our final analysis sample included 710 women. Next slide, please. Of the calls due at each time point, day 14 saw the highest percentage of calls completed, which was 63%. 78% of participants were reached at least once, and 35% were reached at all of the relevant time points. Next slide, please. So there's a lot in this table, so I'll just mention some of the key information. The age group that had the highest percentage of women was those aged 25 to 29. Among 30% of deliveries were preterm, and 59% were multiparous. Next slide, please. This table also contains a lot of information, so I'll just point out a few things. 32% of deliveries involved any antibiotic use, and this varied widely by hospital. 4% of deliveries were stillbirth. That's 29 stillbirths out of 710 participants. Next slide, please.
Hello, my name is Maxine Pepper, and now we turn to the initial results related to the number of new infections identified at each time point. In the table, you can see the percentage of women reached reporting symptoms corresponding to one of our infection definitions. And for maternal infection, we focus on cesarean surgical site infection, urinary tract infection, endometritis, and mastitis. And in row 5, you can see the total number of any of these infection types. As you can see, 10.7% of women reached on the day 28 call reported symptoms of infection, and 22% of women reported symptoms on day 7. For newborns, we asked about symptoms of perinatal severe bacterial infection, and up to 17% of women reported such an infection, with the highest percentage on the day 7 call and a decline over the subsequent time points. Next slide, please. So now we move on to our other outcomes of interest. And at each of the time points, we also asked women whether their babies were still alive and whether they experienced any problems related to feeding them. Focusing on mortality after discharge, we unfortunately identified 3 babies which died over the course of the studies. For feeding problems, 6.6% of women reported having issues on the day 7 phone call, but this percentage decreased over time to 0.7% on the day 28 call. Only on the last call, the day 28 call, we also asked about fistula symptoms and applied the Edinburgh Postnatal Depression Scale. While we identified no women with fistula symptoms, there were 5.7% meeting our cutoff of referring them to mental health services. Next slide.
Yeah, thank you. To complete this analysis, we conducted the interviews with staff nurses who were involved in this PARL study. And what we returned is that PARL study is seen as feasible. So the implementation of this study is seen as feasible, but there are some concerns about funding and supplies. But in general, the nurses found PARL as a very good idea. Next slide, please. So according to the utility of this PARL approach, PARL provides essential information that contributes to improving the quality of postnatal care. But challenges exist in reaching people and also in navigating technical problems with the software. But women were very interested in being contacted, highlighting the importance of overcoming these barriers. Next slide, please. So for the acceptability, the women in the study were delighted with the study and expressed a strong desire to continue this type of follow-up, appreciating the interest shown by the nursing staff in their well-being. So this positive feedback highlights the potential impact of regular follow-up on women's health after childbirth. Next slide, please. This approach is sustainable. It can be sustainable, but there are some conditions to implement this. The first one is about the length of the questionnaire, which needs to be shortened. Also, we need to dedicate some 1 or 2 nurses to the calls, because it is not possible to make it for everyone, but we need to dedicate some nurses just for these calls. And the benefit can be for all women, regardless of delivery mode, not only women who deliver by cesarean, but it can be extended to all women and also to the other pathologies and surgical procedures. Next slide, please.
Thank you, Jean-Lambert. Now I'll talk a bit about our conclusions. Next slide, please. So our results show that women with cesarean delivery in the DRC are willing to be called by hospital staff in the first month after delivery. The PARL questionnaire identified likely cases of infection. Most infections were identified by the day 14 call. In terms of staff, there's general acceptance, but any future implementation should really consider the impact on the hospital workflow and also areas of the questionnaire that can be shortened. Next slide, please.
So the aim of our study was to implement and test the implementation of a telephone questionnaire and assess its utility as an ongoing surveillance tool. And we found that it was feasible to assess infections via telephone reports of symptoms. However, our study also highlighted the challenges of integrating PAL within hospital workflows. We are pleased that there's evidence of staff and mothers valuing PAL, both in the sense of it being acceptable and desired. And finally, within our data, we can show that PAL identified additional infections beyond those that women already sought care for. And this indicates that PAL created additional opportunities to direct women to care. Next slide.
Yeah, thank you. So to optimize PAL, as we said earlier, we need to dedicate staff with protected time to address competing duties. Also, we need to consider areas of questionnaire that can be shortened. Also secure some funding for PAL phones, tablets, dedicated staff. And also the analysis show that we need to consider calls at day 10 and day 28 rather than 7, 14, and 28. This PAL approach can be expanded to all women, not just those with cesarean delivery. And the implementation can be introduced with the routine monitoring evaluation plus the cost effectiveness analysis. Next slide, please. So before ending, we would like to thank also the women and children in the DRC for whom we made this study, and also acknowledgement about the support, the technical support we received from other colleagues, HQ and USAID colleagues. Thank you so much, and we are open for questions. Thank you, Vandana.
Thank you so much, Jean-Lambert, Ona, and Maxine. You'll see in the Q&A that many questions are coming in for you, as they have for the other speakers. Before we go to the open discussion period and our solicitation of ideas from our participants, I'd like to turn over, next slide please, to Debbie Armbruster from USAID. And keep moving. Thank you. Jean-Lambert has covered this. Thanks. Debbie, just turning to you for your reflections on what we've been hearing in terms of needs, opportunities, either on the specific innovations that have been shared or what this community of practice can do. Thanks so much for joining us, and over to you.
Yeah, thanks, Vandana. And it's a real honor to be here. And first of all, I want to say I speak today on behalf of the USAID team that supports this Safe Surgery project, the Momentum Safe Surgery for Family Planning and Obstetrics, with Elizabeth Ployce and Premila Bartlett at the helm. I want to start with a thank you to everybody who's joined this. I was really excited. The numbers got up to 242 participants, which shows a really keen interest to learn more and improve the surgical care for all the women and newborns who need it. And then I also want to give a huge thanks to Vandana and the whole team with a congratulations for a really outstanding program and excellent country activities, as well as cutting edge research, which we could see, and evaluation being conducted through the project. This community of practice is another excellent initiative by MSSFPO. That's a mouthful, but it's the Safe Surgery Project, which provides a place for all working in this area and interested in surgery to join, share, and learn. And from today, I think we've learned about the importance of communication and teamwork within the surgical team and when surgery is being performed. And it's also offered you a checklist, or at least something you can begin to use in your facilities and within your programs. Additionally, we looked at some innovations that are important to be practiced that they were working on in Rwanda. But some of what they were telling us is we really need to be practical and ensure that it's possible to use these innovations, and that's probably more important than the shiny gizmos that people do tend to move towards. And this last presentation was really great because it really, and it's one of the things I've enjoyed or appreciated about this project, is that they've really looked at problems that nobody has really taken on before. And that's the issue of postpartum. How do we follow these surgical patients and make sure that, in fact, you know, not only did the surgery go well, they were able to go home, but as time goes on, they don't develop infections or run into mental health issues. And so really looking at the possibility of using phone calls. And I thought, again, I appreciate research that's realistic and provides both positive, you know, the pluses where it works well, but what you need to do to ensure scale up or use in your countries. And so the issues of needing more kind of special time for the providers, because it was quite time consuming, being probably a really important one to think about if you're going to utilize these different innovations that are being tried and utilize the research coming forward. So again, thanks to everybody who's done that. I do want to say that this is USAID's MSSFPO's, our first surgical project, or a project on safe surgery. And it's really impressive to see and hear the lessons learned and the various programs that are being implemented. And I'm sure that many of you, given there are many participants here, are also working on things that I hope can get shared through this community of practice. They can be really powerful tools. The Safe Surgery Project has also been very creative and thoughtful, including the country teams, to identify gaps. And these gaps are areas where many of you might be able to pick up on the research and move some of this forward. And we need to learn more about the challenges, both within kind of the surgical area, but within the health system that's needed to support actually safe surgery. In setting up this community of practice to share and learn from each other, we've also heard about, you know, some of the things that the statistics that make it so important to do this. The 2019 ASOS study, which showed that women in Africa had at 50 and sometimes 100% higher chance of mortality, has really given us all pause and really pushed us to try to make sure that we're identifying what these issues are and to make improvement. And to wrap up, the MSSFPO program, along with organizations supporting safe surgery, many of you, are paving the way for countries to take up the challenge to strengthen safe surgery programs in all countries, to set better standards or higher standards, and to strengthen to hold everyone accountable to ensure that women's lives and newborns' lives are saved. There remains a lot to do, and I hope this community of practice has motivated you, given you new ideas to work on, and will continue to share best practices, new research and data on innovations and lessons learned. And hopefully many of you will be participants in future meetings. So a big thanks to MSSFPO for hosting this.
Merci infiniment à l'équipe de MSSPO pour ce travail exceptionnel et que je veux croire que vous avez tous apprécié la réunion. Bandana, la parole vous revient. Merci infiniment pour ce partage et nous saluons surtout le contexte que vous avez dressé sur l'importance du travail et nous valorisons vraiment votre appui sans faille au niveau de l'USAID à ce projet PARLE. Prochaine diapo, on a pas mal de questions en tout cas qui fusent de part et d'autre depuis le chat. Donc ça se fait par écrit. Merci de bien vouloir y accorder votre attention. Il y a quelques-unes des questions que je voudrais ici répondre pour l'intervention de nos différents panélistes. D'abord, c'est le pourquoi. Est-ce qu'on peut aller à la prochaine diapo? Nous voudrons surtout vous rappeler à nouveau notre site dédié à la communauté des pratiques. Et alors que nous répondons à vos questions,
On two things. What are some topics you'd like to see covered at future gatherings of this community of practice? We've already heard a couple of ideas in the questions that have been asked and comments that have been made, but please feel free to share the topics, the challenges that you think should be discussed in a future meeting. And if you have resources you'd like to share, drop links in the Q&A using the Q&A function, and we'll be compiling those. As we mentioned, we are going to put a resource clearinghouse up at this website, so we'd love to include the work participants have been doing. So share your questions, share topic ideas, and share resources. And while you do that, I'd like to ask our panelists to come back on video if they'd like to, or as they answer questions. And I'll start with one to the team that worked on the Cesarean Safety Checklist, Rose, Meg, or Manoj. There were a couple of questions about the specificity of this tool. So what are your thoughts about how specific the prototype that's been developed is to India? What are the aspects of it that are universal, context invariant, versus things that are really targeted to the Indian context? And perhaps also your thoughts about the utility of this checklist in emergency cesareans versus those that are planned. So over to you for that first question. Thank you.
Sure. Thanks so much for that question. I'm happy to answer that. So the first part of the question was really about how context specific the checklist is. And one of the design principles that we really tried to stick to in our process is that we wanted to be very clear about who our end users are. And for this project, we explicitly engaged clinicians and policymakers and quality improvement specialists, specifically from public facilities in India. We engaged with people from 4 different states within India, and those are the folks that we also invited to that human-centered design workshop. And there is a design principle that, again, we wanted to follow around making sure that if we design for everyone, then it's almost as if we design for no one. So we just wanted to be extremely clear about who our end user audience is as we went through the design process. That being said, I do feel very confident that most of the checklist is actually core material or invariant material that I think is generalizable across settings. We were very clear we were looking at public facilities at the secondary level in those 4 states in India, but I think the majority of the checklist content is generalizable, given that the process of cesarean birth care is relatively similar across settings. That being said, there certainly are things that we identified in the design process that are specific to what we heard about from our end users in those particular facilities in those 4 states in India. So some examples that I'll give is we included in our checklist the opportunity for a birth companion to be present in the operating theater. We know that that's not universal. That's not something that is possible in all settings. So that is one example of potential adaptations or modifications that might need to be made. Similarly, within our checklist, we do acknowledge an opportunity for having the mother watch the cesarean birth through a clear drape, for example. Again, that might not be possible in all settings. That might not be a supply that's available. So that might not be an option that's offered to patients. Other sort of more flexible elements that we had a lot of conversation around was who is part of the checklist team. And we noted that in different facilities, it varied whether it was a nurse or a pediatrician who was present for the baby, whether it's a baby resuscitation or special care needs for the baby at the time of birth. And so we recognize that that also varies across settings. The last thing I'll mention is, for the most part, the clinical guidelines are relatively standardized, following, for example, WHO guidelines. However, we recognize that there might be variable implementation of some of those guidelines across settings. So, for example, vaginal preparation before cesarean might vary a little bit setting to setting. So those are just some examples of what might be slightly flexible or might need to be adapted for different contexts. But the majority of the care in the checklist, we believe, is generalizable because the process of cesarean birth care is relatively consistent across settings. But we would welcome further conversation with folks from different settings to really see how adaptable the checklist is in different settings. And then to your second question about emergency cesareans, I did see that question in the Q&A as well. And emergency cesareans, the checklist that we developed is comprehensive for every cesarean. Whether any adaptations need to be made due to time constraints in an emergency cesarean, we would still need to explore during the testing phase. But what we have created is really meant to be comprehensive for any person undergoing a cesarean. I think the unique circumstances of emergencies is something that we would need to really consider as we pilot test in the next phase, the checklist in real life.
Thanks so much, Rose. That's a really helpful response, and hope it's useful for participants who are considering already, once this checklist is available after testing, whether and how it may be useful for them as well. Thank you for that. The next question I'd like to target to Ona, Maxine, and Jean Lambert on the Pearl study. But Bethany, you may also have thoughts on this given your work in Rwanda. And the question is, in terms of the postpartum calls to women after surgery, it would be valuable to collect data on outcomes. For women with identified infections, did they return to get treated? Are there additional morbidities or mortality related to those infections? So I know your work is ongoing, your analysis is ongoing, but if you have some initial thoughts on that, that would be great. Thank you.
Thanks, Vandana. Yeah, so it is a limitation, and we don't really know what happened to women after the phone calls. So we didn't follow up with participants or review routine hospital data for those who reported infection symptoms or also signs of postnatal depression. We do have some data on care seeking. So for those who said they were readmitted to the hospital, we asked what treatment they received. And then among those who had infection symptoms, we can also report the percentage that sought help, who said they were readmitted, and those who received treatment. So we will be reporting on this on the data that we actually do have in the full analysis. But it's a limitation that we didn't follow up with clinical records.
Thanks for that,
I don't
Ona.
know, Jean Lambert or Maxine, if you want to add anything to that.
Yeah. No, I think
You don't have to.
Ona, you have answered to the question. We didn't go deeper to follow clinical data to see if those women came back and what happens with them. Thank you.
Thank you. And I'll stay with this team just for a moment before turning to Bethany. And another question that came up, and I think Jean Lambert's comments in the presentation addressed it to an extent, but perhaps any of the three of you might want to reflect on this. And the question was, given the severe health workforce shortages in the region, not just in DRC, but in the region, what are your instincts or thoughts on the scalability of an approach like this for this kind of telephonic follow-up? Any thoughts you have on what it would take to scale this, or how feasible you think it might be in that workforce context? Thanks.
Jean Lambert, do you want to take this, as you know the context better? How scalable do you think?
Yeah, for sure. The first impression when we did this study is how acceptable the hospitals have accepted this approach, and also the approach was very acceptable by patients, by women themselves, because it was a kind of they said it's strengthened the follow-up process of women, and women were surprised to be called back by nurses after they left the hospital. So as I said in the presentation, the limitation can just be about funding. If the hospital can secure some funding for technical materials like tablets, phone calls, and mega for internet. So this approach can be implemented in a large scale without any issue. Because, and I'm answering another question, all the process of the recruitment and the calls were done by hospital staff. After a short time of training, we just train the hospital staff to do the recruitment, to understand the criteria, and also to make all the calls and to register all the data. So it is possible to be implemented in large scale. So I think I'm comfortable for that. I don't know, Ona, if you have a comment.
Yeah, I think it's just about number one, yes, ensuring. Ideally, it would be great to have dedicated PARL staff. If that's not possible, protecting staff work time to allow for some time to make follow-up calls. Just exploring different ways that it can be integrated within the current system and the workload. We do have some ideas about how we can shorten the questionnaire in the future, and also potentially longer training time periods as well could help. So I think it can be. I think it has the potential to be scalable. We just need to work out a few practical issues.
Excellent. Thank you so much. And I think part of that response also speaks to the idea of what a scope of work is, and that this kind of follow-up is actually a legitimate part of a nurse's scope of work or of the care team's scope of work, and that care does not end at discharge. So lots of insights there. Thank you. Bethany, I'd like to turn to you. A couple of questions that are similar to what we've heard for the PARL team, and then one that's, I think, directed specifically to you. So first, any thoughts you had on how, in your context in Rwanda, how were women referred back for care if issues were identified, infections were identified? Two, what challenges did you face, or do you think this model faces related to connectivity, phone connectivity in rural Rwanda? And then third, there are several questions about antibiotic stewardship. And I would love to hear your thoughts on that in the context of the work you've shared. Thanks so much.
Great, thanks. Definitely a lot of overlaps to what the previous team just replied. So with the surgical site infection referral, there's a question in the chat, one around the high rates of SSI. So I'll just link that in here. From our series of studies, one of the reasons we believe it's so high in our context are post-operative exposures. And we have several studies that link the dry season and the lack of predictability of available water at the hospital to surgical site infections. And so in responding to that, colleagues at those hospitals have found more stable supply sources for water, and then also changed where they put hand washing stations so that when the hospital's are without water, people can maintain protocols, and that's actually decreased our infections by half. So, I think there's a lot of post-operative exposures that are happening in hospitals and also in patients' homes during recovery that are very addressable and should be addressed. So then once someone has a surgical site infection specific to our tool, so in the previous studies, all women are coming back for surgical site infection diagnostics because that's how we validate our studies. That's how we know that our infection tool is a good has good diagnostic properties. In that case, they get actually higher than standard of care because they're at the hospital. They're being seen by clinicians, by GPs at the hospital if they're identified as surgical site infection positive. I thought the question was great about, do we know what happens to them after? And we actually have just enrolled a cohort of 60 women who have surgical site infection, 60 women who have postpartum depression, and then 60 women who had cesarean delivery but don't have either of those complications, just to see what their recovery looks like a year after, what types of care are they seeking, but also how well do they return to their day-to-day lives after cesarean delivery with those complications. So to be continued, we'll be able to answer those questions soon. And then our randomized trial will help us answer whether or not the home use of these tools actually encourages women back to care faster, and is able to identify complications faster and get them back into care faster than just the standard follow-up, which is to go back to the health center every 5 days after cesarean delivery. So to be continued, we'll be able to better answer those questions. The questions around scalability and connectivity to me are related. So we are really both trying to develop tools that could be thought about in other contexts, but really are specifically developing for Rwanda. And so one of those is around the connectivity and the issues around connectivity. One of our first studies actually used phone calls. And what we found is that 30% of women were not reachable by phone calls, and they tended to be the least educated, the most remote, the least resourced women. And that's why we've not pursued phone calls after this. So basically it's issues around connectivity. So when we call them, can the phone call go through? But it's also issues around cell phone ownership. And so when we call them, do they actually have a phone, or is the phone with a partner, or is the phone with a neighbor, and we can't actually get to the woman to do the assessments. So that's one of the reasons we've dropped phone calls. Connectivity is an issue there. And so we've developed our mobile app to be fully functional without needing a cell network or internet connection. So when the community health worker goes to the woman's home, it can all be operated offline. Even the processing of the machine learning algorithm does not need to go to a server. We've developed what's called a mobile library that allows the algorithm to just operate on the phone. And that's been really important to us because we don't want to have a community health worker go to the home, be able to do a series of assessments, but not be able to test for surgical site infections, because then the woman has to go back to the health center anyway. It really loses the benefit of that encounter. And then the last comment around antibiotic stewardship, I think it's so important. There was another one around antimicrobial use and AMR patterns. So we've actually found in our studies that there's high levels of antibiotic use, both pre and post-operative. Most women are getting sent home with antibiotics. And we really do think we need to address better antibiotic stewardship through these interventions, including it's part of the reasons why community health workers are not just treating at home when they see surgical site infections. We want it to go back and be confirmed in a clinical setting. Part of the issue, and I think this is important to highlight, in a study that we did, 100% of surgical site infections were resistant to the primary antibiotics available at district hospitals. So that really points to, one, we need to be doing better stewardship to curb the resistant patterns that we're seeing. But two, we have to identify surgical site infections early, because if they're already resistant, then debridement's going to be the best treatment option. And so getting it early and being able to treat effectively just by flushing the wound instead of needing antibiotics to be the center of the treatment is going to be really critical. So I'd be curious what other teams have to say about how they're thinking about antibiotic use and antimicrobial resistance in their work. But I do think as a community, we really need to be centering those concerns in our work as well.
Thank you so much. Thanks for that comprehensive response. And you see a lot of interest on that topic around antibiotics and resistance in the chat. I think that there's a question that I'd like to bring back first to the Cesarean Safety Checklist group. And then there are a number of questions that are related that have to do with health worker motivation, retention, and sustainability. So we'll come to those as well. So back over to you, Rose, Meg, or Manoj. There is a question about the role of midwives. And I think because the checklist is so much about teamwork and team communication, I'm wondering if you'd like to talk about how the checklist positions the midwife in that care team at this moment of handoff, or any other thoughts you have about the role of midwives in addressing the challenges that you identified at the start of your presentation around quality and safety in cesarean delivery. Thank you.
Sure, absolutely happy to talk about that. And thank you for even asking about the importance of bringing forward midwives as part of the care team. I think that this certainly comes up in the handoff processes, as you just mentioned, Vandana, around who is caring for the patient mother before cesarean and who will be caring for her after cesarean. In most settings, I don't believe that midwives enter the operating room, though there may be settings certainly where midwives might assist on cesareans occasionally, but that might be another kind of context specific adaptation that would need to depend on the different settings. But certainly inclusion of midwives as part of the care team is absolutely central to the checklist. The other piece I wanted to also kind of amplify that we learn really from our midwifery colleagues in terms of being leaders in this is really thinking about respectful maternal newborn care. And that is really one of the most exciting innovations that I think we were able to bring forward in this particular checklist prototype. As I mentioned, we really didn't see a lot of other guidance on what does respectful maternal newborn care look like within the walls of the operating theater. There's a lot written about this topic broadly in birth care, in labor, in prenatal care, even in postpartum care. But within the walls of an operating room, there's actually not as much written. And as you all know, the interesting thing about cesarean birth is the majority of times the woman is actually awake and conscious, which is not the case for many other surgeries. And this is one of the reasons why we didn't think that the WHO Safe Surgery Checklist alone was enough to cover some of the unique features of cesarean birth, one of which is that the mother is awake, conscious, and could be engaged as part of that process. So I think that our inclusion and innovation around what does respectful care look like for both the mother and the baby, I certainly credit many of our midwifery colleagues. This is something that is foundational to midwifery-led care, but we're bringing it into the operating theater, which is often a space where midwives are often not, though not in all places. There may be some places where midwives do assist on cesareans, but may not be the typical situation. But certainly bringing them forward as part of the care team. And again, our emphasis was on communication across the care team, including the patient herself. So midwives being fundamental to that care team would be part of the checklist process in addition to the patient.
Thank you so much. Really helpful. And to echo you, really appreciate the question about midwives, who are such an important part of all maternity care, and including in when that care becomes surgical. And there are a number of questions around health worker motivation, payment, retention, including community health workers or volunteers. So before I turn to you, Bethany, on some of those, I know you're putting something in the chat as well. Maybe over to the Parle team. You know, there's a question about equity, and this was also addressed, I think, in Bethany's one of her comments about the 30% of women who could not be reached, ownership issues. So to the Parle team, just curious if you want to elaborate at all on any learning or any thinking around whether the phone calls do reach everybody who might be left out. Any thoughts you have on the equity side of it, and then we'll come back to this. And if you'd like to answer, there's also a question about how could those nurses or the staff who'd be making those calls, what could be ways to motivate or support them to take on an additional layer of work, given everything else they do? Thank you.
Thank you, Vandana. I think I don't have the data to hand, but I believe that most women did have access to a mobile phone. So I don't know if my co-presenters know that off the top of their head. So there weren't many participants, I believe, that wanted to participate but could not because they didn't have a mobile phone. But we can look into that a bit more. And the second part of your question was what?
It was really on how could those staff be supported to be motivated to add another layer of work. So you've talked about the scalability piece, but there was another question around what might help, what might be motivating to take on that additional piece of work.
Yeah, I mean, ideally it would be, and I was typing this in the chat, somebody else answered this, asked this question. I think ideally, you know, it wouldn't be seen as an additional part of their job. It would be integrated within the workflow. So if staff could see that, you know, patients do come back and get treated, that could potentially be motivating, rather than just wondering what happens after they leave the hospital. To see the complete cycle of treatment, I think might be motivating. And that was also shown in the qualitative work, I think, because people really valued that contact. I don't know if Jean Lambert, you wanted to add to that or not?
No, thanks. It's okay.
Thanks. Bethany, we're going to have the last question over to you before we come to wrap up. And I know you've also addressed this a little bit in the chat, and it's this question about community health workers or volunteers, their payment, if they do receive money to do this additional work, and similar to the question just now to Ona, what are strategies for motivation or for retention for continuing approaches that appear to be promising using that cadre? Thanks.
No, really important question. So I want to distinguish the work that we do as part of evaluating whether or not these tools are even possible to work in this setting. So in our studies, the colleagues that we engage as community health workers to evaluate whether or not these tools are feasible, acceptable, and have clinical impact, they are well compensated for their time. We make sure that all of the expenses they incur for travel, that those are well covered. So we make sure that we're fair and just in our research. The pathway to scale and sustainability here is the fact that these are already members of the Ministry of Health workforce. So, you know, every country is different. I can't comment on all countries, but in Rwanda, community health workers are agents of the Ministry of Health. They're employees. They have job responsibilities. They have supervision structures. So they are already members of the workforce. And what we're really trying, our pathway to sustainability and our pathway to scale here is the fact they're already going to the home. So can we capitalize on that exchange and really add on the more complex assessments that are required for safe post-cesarean follow-up? If this was a separate visit, then I think the Ministry of Health would have to think about, you know, how do we either hire more people because there's more work, or how do we make sure that adding on these tasks are not distracting to other responsibilities. The final thing I'll say about community health workers in Rwanda, and this is happening in more places, is part of the plan and workforce development is to empower all community health workers with smartphones in Rwanda. And so really the question is, what apps do we put on those phones? What machine learning tools do we put on the phones to really, again, take advantage of that platform to support more complex and polyvalent care? I think I answered all the questions, but
you did, absolutely. Thank you so much. So as we come to the wrap up, I really appreciate the participants who've been sharing ideas for future webinar topics for this community of practice. We are taking all of those and making a list. Please feel free to share any other resources. We've really appreciated the enthusiastic question and discussions. We've seen, if I'm looking at my numbers correctly, I think almost 70 different questions have come in. And I want to thank all of our panelists who've been answering those live and in the chat, and really give a big thank you to Rose, Megan, Manoj, Bethany, Ona, Maxine, Jean Lambert, and Debbie for making this first global virtual convening of the community of practice so interesting and stimulating. Many thanks to all of you. Please stay in touch, stay connected through the website you see there. And we look forward to seeing you at the next gathering of this community of practice. Have a good rest of your day and evening, everybody.